Continuing on page 210. The third rule for suctioning is place the tip or catheter where you want to begin the suctioning and suction on the way out. Most suction tips and catheters do not produce suction at all times. You have to actually start the suctioning. The tip or catheter will have an open distal end where the suction is delivered. It will also have an opening or port in the proximal portion. When you put your finger over the proximal port, suction begins from the distal end. Proximal is like closer, and distal is farther away. Like, think of it like proximity means being close, and distance is farther away. So proximal is closer and distal is farther away. It is not necessary to measure when using a rigid tip. Rather, you should be sure not to lose sight of the tip when inserting it. However, do measure the suction catheter in a manner similar to an oropharyngeal airway. The length of the catheter that should be inserted into the patient's mouth is equal to the distance between the corner of the patient's mouth and the earlobe. Carefully bring the tip of the catheter to the area where suctioning is needed. Never jab or force the suction tip into the mouth or pharynx. Then place your finger over the proximal opening to begin the suctioning, and suction as you slowly withdraw the tip from the patient's mouth, moving the tip from side to side. Suctioning is best delivered with the patient turned on his side. This allows gravity to assist suction, as free secretions will flow from the mouth while suctioning is being delivered. Caution must be used in patients with suspected neck or spine injuries. If the patient is fully and securely immobilized, the entire backboard may be tilted to place the patient on his side. For the patient for whom such injuries are suspected but who is not immobilized, suction the best you can without turning the patient. If all other methods have failed, as a last resort, you may turn the patient's body as a unit, attempting to keep the neck and spine in line. Suctioning should not be delayed to immobilize a patient. It may also be beneficial to manually remove large particles prior to or during suctioning. As always, caution should be taken in placing your fingers in a patient's mouth. However, a shallow sweep will often help remove particles not able to be suctioned through the lumen of the suction device. The rigid suction tip or flexible catheter should be moved into place carefully and not forced. Rigid suction devices may cause tissue damage and bleeding. Never probe into wounds or attempt to suction away attached tissue with a suction device. Certain skull fractures may actually cause brain tissue to be visible in the pharynx. If this occurs, do not suction near this tissue. Limit suctioning to the mouth. Suction devices may also cause activation of the gag reflex and stimulate vomiting. In a patient who already has secretions that need to be suctioned, vomiting only makes things worse. If you advance a suction catheter or rigid suction tube and the patient begins to gag, withdraw the tip to a position that does not cause gagging and begin suctioning. Keeping an airway open. Definitive care. At times, keeping an airway open will exceed the capabilities of the basic EMT. Medications and or surgical procedures may be necessary to resolve the cause of airway obstruction. As an EMT, you should rapidly evaluate and treat airway problems, but also quickly recognize the need for more definitive care. In some systems, definitive care may be an advanced life support intercept. In other systems, definitive care might be the closest hospital. Either way, you must know your local system resources and recognize your capabilities and limitations. Special considerations. There are a number of special considerations in airway management. Facial injuries. Take extra care with the airway when patients have facial injuries. Because the blood supply to the face is so rich, blunt and penetrating injuries to the face frequently result in severe swelling or bleeding that may block or partially block the airway. Frequent suctioning may be required. Insertion of an airway adjunct or endotracheal tube may be necessary. Obstructions. Many suction units are not adequate for removing solid objects such as teeth and large particles of food or other foreign objects. These must be removed using manual techniques for clearing airway obstructions, such as abdominal thrusts, chest thrusts, or finger sweeps, which you learned in your basic life support course and are reviewed in Appendix B, Basic Cardiac Life Support Review, at the back of this book. You may need to log roll the patient to a supine position to clear the oropharynx manually. Dental appliances. Dentures should ordinarily be left in place during airway procedures. Partial dentures may become dislodged during an emergency. Leave a partial denture in place if possible, but be prepared to remove it if it endangers the airway. Pediatric note. There are several special considerations that you must take into account when managing the airway of an infant or child. See Figure 9.9. Anatomic considerations. The mouth and nose of infants and children are smaller and more easily obstructed than those of adults. In infants and children, the tongue takes up more space proportionately in the mouth than in adults. The trachea, or windpipe, is softer and more flexible in infants and children. The trachea is narrower and is easily obstructed by swelling. The chest wall is softer, and infants and children tend to depend more on their diaphragm for breathing. Management considerations. Open the airway gently. Infants can be placed in a neutral neck position, and children require only slight extension of the neck. Do not hyperextend the neck because it may collapse the trachea. An oral or nasal airway may be considered when other measures fail to keep the airway open. In suctioning infants and children, use a rigid tip, but be careful not to touch the back of the airway. Figure 9.9. Comparison of child and adult respiratory passages. Child has a smaller nose and mouth. In child, more space is taken up by tongue. Child's trachea is narrower. Cricoid cartilage is less rigid and less developed. Airway structures are more easily obstructed.